Chaos exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Good afternoon. My name is Amy Salmon. I'm a scientist here at CHAOS, and it is my pleasure to introduce our speakers for today. Before we begin, I'd like to acknowledge that the land on which we gather is the unceded territory of the Coast Salish peoples, including the Musqueam, Tsleil-Waututh, and Squamish First Nations. It is my pleasure, as I said, to introduce Beth and Sandra. Dr. Beth Snow is a scientist here at CHAOS and our program head for program evaluation. She is leading the evaluation of CST. Apart from that, she is also the president of the Canadian Evaluation Society's BC chapter and a credentialed evaluator. Sandra Wu is an evaluation specialist here at Providence, and she is working on the CST evaluation. Take it away. Our slides don't appear to be up there. They were earlier.
Am I coming back?
No.
Okay.
They were earlier. Oh, yeah, once the video turned on, it might have.
Oh, this is done.
Perfect, thank you. Okay, thanks. So we are here today to talk about the evaluation so far of the Clinical and Systems Transformation Project. As I'm sure most people in this room know, Clinical and Systems Transformation Project is a project across 3 health organizations to bring a shared electronic record known as CST Cerner, as well as standardized clinical practices across Vancouver Coastal Health, PHSA, and Providence Health Care. These 3 organizations are all coming from sort of different starting points in terms of how they operate. So they're implementing Cerner into about 40 facilities, including hospitals, residential care, ambulatory care. They're running primarily on paper patient charts before Cerner, but there is a range of different mixes of information technology systems being used across the different sites. And across the different sites, there's varying levels of IT functionality, both across the organizations and even within the organizations as well. And there are some different practices and workflows across organizations and within sites, and that's sort of the starting point before Cerner goes live. A number of things are being implemented with the Cerner system. So it is a shared electronic health record. So your health record, if you're at Lionsgate Hospital, you'll be able to see everything that happened there once it goes live here at Providence. And then as more sites are added on, it's shared across all the sites. There's going to be an implementation of computerized provider order entry. So that means that the person placing the order will actually have hands on keyboard and be entering their orders directly into the Cerner system. There'll be electronic documentation. So that can either be through hands on keyboard or it can be through voice to text front-end speech recognition that you do your electronic documentation. And there'll be barcode scanning for medication administration. So when a nurse is administering a medication, they will scan a patient's wristband, they'll scan the medication package, it'll check that those things go together. Together, the whole process is sometimes referred to as closed-loop medication, and it's intended to improve medication safety. There's a number of other things that are implemented in Cerner as well, but these are some of the highlights. There's also standardized order sets and standardized screening tools that are used. And these electronic functionalities allow for things like alerts to happen. So if you're placing an order and you get an alert and it says, oh, don't order that medication, the patient's allergic to it. So it can check those kinds of things. Or you're scanning a patient's wristband in the package of the medication and you get an alert that says, oh, that's the wrong dose for this patient at this time, and helping to prevent those types of errors from happening. From the evaluation perspective, so that's what our team is working on. The purpose of the evaluation is to try to determine the value of the CST project as it is implemented and to learn what's working well and where things can be improved. Our overarching evaluation question is, to what extent is the CST project achieving its goals? We are also interested in some of our sub-questions. What helps? So in areas where things are going well, what is it that allows things to go well? Also, what's hindering? So in areas where things aren't going as intended, what's getting in the way? So we can learn how to improve the system and the practices. We're also interested in differences in different contexts. So I mentioned this is getting implemented in a lot of different sites. So do things that work in an urban academic hospital work also in a small rural site? Do things that work in acute care hospitals also work in BC Cancer's primarily ambulatory type of setting? Those kinds of questions. So we want to see what are the similarities and differences with different contexts. We're also interested in unintended and unanticipated consequences. So we know in any complex system that things will emerge that you can't predict, and so our evaluation needs to leave space for identifying those things that nobody anticipated or that people did anticipate that are undesirable, to see if those things actually come to fruition. In order to know if the project achieved its goals, we needed to know what the goals were. So the project set out a number of broad, long-term goals. So they include things like reducing medication-related adverse events, reducing time to therapy, improving the ability to use data, so having more and better data that we can use for improving how our facilities run, and also for research. So we can't evaluate all of this all at once, nor would we expect all of these things to happen right away. So there was a further focus down to a few specific clinical priority areas to focus on to start. And these are decreasing order-related medication adverse events and decreasing medication administration-related events, intervening earlier for septic patients, earlier engagement of rapid response teams where sites have rapid response teams, where not every site has those, but where they don't, they'll still be implementing modified early warning score, and if you have pediatric patients, pediatric early warning score. So these are scores that identify this patient might be deteriorating. We need to take a closer look and do some intervention there. And then two areas that were added more recently in the project are improved communication of patient treatment wishes, and this is focused really on advanced care planning, and decrease in non-medication related errors, and this is focused on labs and transfusions. Because another thing that's recently been added is the barcode scanning process for when nurses collect lab specimens. So that's recently been added into the mix as well and will be implemented at Providence. In terms of our timeline and our roadmap, Cerner went live at some of the coastal sites, the Lionsgate and Squamish hospitals, and Whistler and Pemberton Health Centers went live in 2018. Next up, again, I'm sure most people in this room know, is Providence going live very soon. Shortly after Providence goes live, 2 weeks later, Burnaby Center for Mental Health and Addictions will be going live. And next year, scheduled for BC Cancer, Vancouver General Hospital, UBC Enrichment Hospitals, Women's and Children's, and the rest of BC mental health and substance use, so their forensic and corrections facilities, and then the remainder of coastal, so Bella Bella, Bella Coola, Seychelles. Within this, there's also what are being referred to as waves. So for some of the bigger sites, there's 3 waves for Providence. So some of the ambulatory clinics won't go live right at November 16th with the hospitals. There'll be 2 waves of ambulatory that will come after that. BC Cancer is also going in waves, so not all 6 of their regional centers will go live together. There'll be 2 and 2, I think. No, 2, 1 and 1. They have 4 waves. And then VCH will also have waves. So there's a number of different go-lives that will be happening over the next few years till we get to the completion of all sites being live. So given all the complexity of all the moving parts of this project, our evaluation approach has to account for those sorts of things. So we are using a complexity-informed approach, being flexible to the emergent nature of the project. So not only do we have multiple different contexts that we're implementing in, we have changing timelines and what we're evaluating. So CST is changing. So as they learn what works and what doesn't, things change, new things are added, like new priorities, new functionalities. So we have to be flexible to those changes. We have to be contextualized, so we have to understand where all these sites are starting from to be able to interpret our findings post-go-live. We have to make sure things are relevant because sites do have differences, and we have to make sure what we're looking at makes sense for them. It does take an iterative approach because of this phased implementation. We're iterating as we go throughout the evaluation process, and it needs to be rigorous. So the data needs to be good quality data collected and analyzed in rigorous ways so it's credible and useful to the sites in the project. For each site or group of sites that go live, we have our data collection timeline, which is basically that prior to go live, we collect baseline data so that we have something to compare when we get post data. In order to know if you improved, you need to know where you started from. So we do a bunch of data collection prior to a go live. As the site goes live, we have a dashboard, which we'll show you in a little bit, of some of the metrics to see to what extent the site is adopting the new clinical practices in the electronic system. We report that daily for about a month, so leadership at the site, and actually anyone who is on a health authority network can look at our dashboard, can see how things are going and respond to that. Post go live, we go back to the site a few months later to see how things have changed and collect our post data. And then we also, after that first month, we have a weekly update of the data. As things stabilize, we move to a monthly update. So right now, our dashboard, for example, for Lionsgate and Squamish or Pemberton is updated every month. So the site can see how things continue to roll out. In terms of the data that we're actually collecting, we've sort of grouped them into a few different buckets. We do have adoption metrics, so this is, are people adopting the CPOE process? Are they adopting the barcode scanning process? That type of thing. We have metrics related to those priority areas, so sepsis, MUES, PEWS, medications. And we also have some balancing metrics. Most of these are data the site's already looking at to see how is the facility functioning to make sure as they go through this really large change that the hospital can continue to function. There are a few balancing metrics that are specific to some specific questions that, that people had. And then we also collect qualitative data to complement the quantitative data, so you have a full evaluation story of what's happening. You can't tell everything from numbers. For methods of data collection, before go live, we're doing chart audits in the paper charts and in electronic charts where there are electronic charts. We do interviews and observations at the site to collect some of our qualitative data. We're leveraging existing data where it does exist. And then post go live, there's a number of things that we pull out of Cerner. So a lot of the stuff that we collect out of paper charts manually for baseline, we can just electronically, we can just extract those out of Cerner. And so the data that's going to be on our dashboard, for example, most of that gets pulled directly from Cerner. In terms of what we found so far, so the coastal sites did go live in 2018. Lionsgate and Squamish went live at the end of April, and Whistler and Pemberton went live in the fall, so about a year ago. And our first evaluation report covered the first 90 days post-go live at all of those sites. And I will now hand it over to Sandra to tell you about our findings.
Thank you, Beth. Okay, so I'm just going to be talking about a few highlights summarizing the Coastal 90-day post-go live evaluation report. Using data that we pulled from Cerner, we saw strong adoption of the computerized provider order entry, or CPOE functionality. That's across all coastal sites with the exception of Pemberton. And we also looked at metrics for medication reconciliation for inpatients at Coastal. So medication reconciliation is essentially reconciling the patient's home medications with what they're going to be taking in the hospital, whether that's continuing, discontinuing, or changing those medications. So the VCH and PHC medication reconciliation policy outlines a structured MedRec process in order to reduce any medication-related adverse events. So the baseline percentages, as you can see here, show the medication reconciliation completion at Lionsgate and Squamish hospitals. This is not applicable to Whistler and Pemberton, as there is no inpatient admission at those sites. And also, as you can see, the discharge medication reconciliation did not exist at Squamish prior to CST go live, so that's why we didn't have a number there. And post-implementation, we saw improved completion of MedRec at both Lionsgate and Squamish. And prior to implementation, medication orders were on paper at these sites, and one of the most commonly identified points in the medication order process that can lead to medication errors is trying to decipher any illegible handwriting on written orders. And since orders are now all placed electronically, illegible orders have been eliminated. Having orders on paper also means that providers had to write down all of the required elements of a safe medication order, and that's according to Accreditation Canada standards, and often one or more of the required elements were missing. And while the percentages of incomplete medication orders does appear high in baseline, it's important to note that often the missing element was the time at which the order was placed or the college ID of the provider. And though it's required, according to those standards, the absence of those elements are generally not considered to be as critical as elements like medication name or dose. And since medication orders in the electronic system cannot be placed without all the required elements, incomplete orders have been eliminated. So the medication order policy also includes a do not use list of elements that was adapted from the Institute for Safe Medication Practices. And such elements could include abbreviations for medication names or symbols, all of which could potentially lead to medication errors. And since medication orders in the electronic system are chosen from a standard order catalog, which has been designed to not include any of those do not use elements, the only place that this could appear is in the free text comment section within an order. So post-implementation, we saw that do not use elements have been virtually eliminated from the medication order. And as well as orders that are written by the provider on paper, we also see verbal and telephone medication orders, and these represent a risk for errors to occur, for example, if orders are not transcribed accurately. And however, there are situations where a verbal or a telephone order is appropriate and necessary, for example, in emergencies. And we did see that the use of telephone orders for medications decreased across sites in post-implementation. Verbal medication orders, on the other hand, stayed the same at LGH, but did increase at Squamish, Whistler, and Pemberton. We also heard from staff that they liked having patient information available to them everywhere and in real time, but they did find that the electronic system was difficult to navigate. Another major change that occurred during the CST Cerner implementation, as Beth mentioned, is the barcode medication administration process, or the scanning of patient wristbands and medication barcodes. The target for scanning was set as 95% of all medication administrations, and scanning is a challenging process to adopt and has room for improvement. There are a number of factors that hindered CST from achieving its goals at this point, and that relates to things that make the adoption of the system challenging. So, for instance, we heard about insufficient hands-on training, as well as lack of training focused on workflows and interprofessional teams that made adoption more difficult, as well as the clunky or the non-intuitive nature of the system did frustrate users, as well as many factors which hindered the barcode medication administration process that we mentioned earlier, and that includes space limitations, device issues, and also issues with orders in the system. Also looked at unanticipated consequences, and as Beth mentioned, that should be expected with any change in a complex system. And some examples of the unanticipated consequences of CST during the first 90 days of that post-implementation stage included issues due to a lack of compatibility with the provincial PharmaNet system and Cerner, which presented a risk for errors in the best possible medication history and medication reconciliation process, as well as orphan lab specimens. So that's resulting from a lack of documentation that lab specimens were collected, and that also represents a risk for errors, harm, and any unnecessary rework that has to be done to recollect those lab samples. We also heard about the effects related to change in roles and workflows, as well as errors that may not have been captured by any existing systems for monitoring errors. And gaps were also noted in the ability of the site to make use of the data that's coming from the new system for analytics and quality improvement purposes. So through speaking with staff at coastal sites, we summarized some lessons learned from the implementation of Cerner, one of which is to provide at-the-elbow support and reduce patient load at go live, and to provide training opportunities that are more workflow-based and hands-on, and planning for sustainment of data reporting, analysis, and use, and going back to the barcode medication administration process we mentioned, that was challenging, so spending time to understand any barriers in various settings and find ways to address them to prevent workarounds. So we can take a quick look at the dashboard here. So this is the dashboard homepage, and this is hosted on the Vancouver Coastal Health Dash website. And as Beth mentioned, anyone with a health organization login can view the site. And if you have any issues with access, please let our team know. So if I just go to, so we can look at the CPOE right here. And our dashboard is interactive, so make sure to take advantage of the filters. But as you can see, CPOE has held quite steady across Lionsgate and Squamish. We can also look at the scanning percentages, and there is variation in scanning across not just sites, but also different nursing units within a site. For instance, we could go to one nursing unit, and that could be quite different from how a different nurse unit is doing. So, so this interactivity allows you to kind of see the differences. Another other area that we just wanted to show was about the turnaround time with stat and now medication orders. So previously, this is information that we couldn't get from the paper system, and now that it's electronic, it's data that we can pull. So what it is that stat and now orders have to be administered within a certain amount of time. So it's stat, that's 15 minutes, and now that's 60 minutes, and we can look at what percentage of that was administered within the target time. And again, you can filter by facility. So. And I will turn it back to Beth to talk about our work for PHC.
I'm sure most people in this room know that Providence is set to go live with Cerner very soon, 24 days from now. The work we've done so far for the evaluation is to collect our baseline data through those methods that I mentioned, through chart audits. We've interviewed physicians and clinicians across MSJ and St. Paul's, conducted observations there as well, and have gotten data for a lot of those balancing metrics from decision support, and we're now in the process of analyzing all that data, and we'll put out a baseline report so we'll know where we're starting from. And then at Go Live, that dashboard, just like you saw for Lionsgate and Squamish, will have one set up for the Providence sites, and it will get updated every day starting on day 2 of Go Live for a month, and then it'll be weekly. And people across the organization are encouraged to go look at it. For the ones, if you can drill down to your unit and see how things are going. The clinical informatics teams will be looking at that. Leadership will be looking at that to identify areas where, for example, more support is needed in the Go Live process, or where some clinical, some quality improvement work might need to be done, those kinds of things. And then post-implementation, we'll do the same thing we did for Coastal. We'll go back to the sites, or come back to the sites, do the interviews and observations. Chart audits, anything we need to do through chart audits, we'll be able to do through Cerner, as opposed to needing to go to the SCM charts that we've done for baseline. And then we'll be extracting data on not just the metrics that are on the dashboard, but there's a bigger set of metrics that we'll have, and then we'll come out with a post-Go Live report for Providence, as well as Burnaby Center for Mental Health, which we're doing at the same time. So we don't obviously have any results to share yet from Providence, but I'm sure we'll be back maybe next year to tell you how things are going here.